Oh, so I see it up on the top here. Never mind.
Oh no, it's okay. What happens is on a recording, we start recording at 1.
Okay.
And once I get it back, I will email it to you.
Okay. All right, great.
There it is.
Okay. Okay. Can we hear it?
I don't think they're started yet.
Okay. Well, here we go.
Okay. And then we're not connected, right? Okay. So she knows I'm here.
And then show all the speakers or just participants?
No, they're participants.
Yes, if she hasn't given you that one, I have. I mean, believe me. Okay. Okay.
The ones you wanted to get.
Yeah. Okay. So,
Honey, don't talk.
Hi, everybody, and welcome. We're going to get started in about 2 minutes. So give us about 2 minutes and we'll go ahead and get started with our presentation today. Thank you for joining us.
Come over here.
Will you take the battery off so you can charge it?
It's good to see a lot of familiar faces on here. Thank y'all for joining us. Thank you. A few more people trying to log on. Okay, everyone, you know what? It is straight up. So I think what we'll do is we'll go ahead and get started so I don't waste anybody's time this afternoon. I know how busy everybody is. And so I will go ahead and get us started, and I'll be watching the room to let people in. And I'm Kirsty, and I work here at Belmont Village Senior Living. And however you heard about our event today, whether it was through the Dallas Morning News or Park City's paper, or if you're on our mailing list, we're glad that you joined us. Thank you for being here with us today. We are so honored to have Dr. Pavasia and Kimberly Berry with us today. We know how busy they are, and they have just such an amazing reputation in the community that it was an honor to get both of them here with us today. Before I switch it over to Dr. Pavasia, if you are not on our mailing list at Belmont Village and you would like to be, please do send me an email and I can add you to our mailing list. We're a senior community located at Turtle Creek and Hall here in Dallas. And we're known for 2 things. One is aging in place. Our residents age in place here at Belmont Village. And we're also known for our programming for a Circle of Friends, which is for residents with mild cognitive impairment. So we have 4 different levels of memory care that we offer. And so if you have any questions or you want to be added to our mailing list or you would like more information, let me know and I can definitely help you with that. At this time, I'm going to now introduce Dr. Pavasia and Kimberly Berry. I'm going to give Dr. Pavasia and Kimberly Berry. They're both with Neurology Consultants of Dallas. Dr. Pavasia is a movement disorder neurologist for the Neurology Consultants of Dallas. and Kimberly Berry is his nurse practitioner, nurse practitioner, also with Dr. Pavasia. And Dr. Pavasia, I didn't even ask you and Kimberly how long y'all have been working together.
So yeah, and thank you for a kind introduction. So yeah, we've been working together for now last 2 years, and
Oh, wonderful, wonderful.
and Kimberly has been a very good, a nurse practitioner, taking care of my patients, and aiding me and keeping the patient follow-ups kind of, as doctors get busier, and this is across the nation, the wait time gets longer and longer. So she is trained in movement disorders, and she is able to help me kind of mitigate that prolonged waiting time. And so she's able to see my follow-up and new patients as well quickly in the practice.
Wonderful, wonderful. Kimberly, would you like to add anything before we get started?
No, well, I've been as Dr. Pavasia said, I've been working in movement disorders with him for the last 2 years. However, I've been working in the neurology space for several years prior to that, in acute care as a registered nurse. So Dr. Pavasia and I, we worked even prior to in the clinic setting. Prior to that, we worked together in the hospital setting as I was working as a nurse. So yeah, it's been a great 2 years here with the practice. So yeah.
Wonderful, wonderful. Before I let Dr. Pavasia take it over, I want to remind everyone to go ahead and put themselves on mute. If you have a question, you're welcome to put a question here in the chat box, and we're going to address all questions towards the end, but he is going to be taking questions.
Thank you, though.
You can private message me. Go ahead and have everybody mute themselves right now. And Dr. Pavasia, I believe you have the screen, so we should be ready to go.
Okay, great. I want to thank you everybody for joining us today, taking time out of your day and paying attention to the slides. We are going to be talking about the Lewy body dementia, and this is a topic not often discussed or talked about. We always focus our attention on Alzheimer's disease and Parkinson's disease, and those are also pretty severe chronic illnesses. But Lewy body dementia, it's a very common as well, and so I think today is a very relevant topic. So today's presentation, Kim and I will be presenting part of the presentation. She will present, and then we'll kind of go back and forth. Before we, move forward, I do want to further talk about our practice here. Here's a, website link, neurologydallas.com. We are a pretty big size private practice, about 17 physicians, 5 nurse practitioners. We have hospital affiliations with Presbyterian Hospital Dallas and Medical City Dallas, where we provide 24/7 comprehensive neurological services. Which includes taking care of our own clinic patients, Parkinson patient or stroke care, or any memory care patients who need acute type of services in the hospital. So we provide them seamlessly at these 2 hospital locations. In the outpatient side, we treat various neurological disorders and movement disorders. With COVID pandemic, we are now providing telemedicine and telehealth services. We do have a relationship with behavioral health partners. They provide us, crucial services like neuropsychological testing, counseling, social worker services. This help kind of complete the picture when patients have those needs. We also have IV infusion center, and the comprehensive rehabilitation center now, which opened up not too long, about 3 months ago or so, I would say. Where we provide physical, occupational speech therapy, swallowing therapy, cognitive, and vestibular therapies. We also will have on-site pharmacy for patients who want to, before they go home from the clinic, they can pick up their medications, or these medications can be mailed to them. And lastly, but most importantly, I want to discuss that, as part of our, ongoing treating the patients, we do provide clinical research trials for patients who would benefit them or who would like to volunteer for them. So we performed trials in Alzheimer's disease, Parkinson's disease, dementia with Lewy body, which we'll talk about today, multiple sclerosis, epilepsy, stroke, so various areas of neurological disorders. And our goal, for the practice in general, our philosophy is to uplift the neurological care in the community. I will now hand it over to Kim. She's gonna present initial of the presentation, and then I'll kind of go back and forth with it. So I'll advance the slide for you, Kim. Go ahead.
So we're going to try to unpack a lot in our day and the time that we have together here. So this is our agenda slide. Initially, we'll answer the question, what is dementia? Then we'll talk about what is Lewy body dementia. We'll talk a little bit about epidemiology and pathology, and then we'll go back over to Dr. Pavasia to go over diagnostic criteria, supporting diagnostic studies. I'll talk about some treatment options, and Dr. Pavasia will speak more about Lewy body dementia research, and we'll have a summary and closing remarks. And then at the end, we'll open up to a Q&A session. So as Caristi mentioned, you can type in your questions throughout the presentation, and then we will, at the end of our presentation, we will go over all these questions and try to answer them as best as possible, okay? So first, what is dementia? So the word dementia is thrown around a lot, I think, very loosely a lot of times, and I don't think a lot of individuals really know what dementia is. So to start out, dementia is not a specific disease. It's a general term, like the term heart disease, that covers a range of specific medical conditions. So the word dementia in and of itself is not a disease, it's an umbrella term for the loss of memory and other thinking abilities that are severe enough to interfere with daily life. It refers to loss of memory, language skills, problem-solving skills, and other thinking abilities that can affect individuals' day-to-day living. The types of dementia here are in the order of prevalence. So Alzheimer's dementia accounts for about 60 to 80% of dementias. The second most prevalent is Lewy body dementia, about 5 to 10%. Then vascular dementia, about 5 to 10%. And then frontotemporal dementia, which is also about 5 to 10%. And then there are others like Parkinson's dementia and Huntington's. And this was received, this data was received from the Alzheimer's Association. So it's pretty up to date information in terms of the statistics and the breakdown of dementia types. So what is Lewy body dementia? Or a little background history. Lewy body dementia was named after the German neurologist Friedrich H. Lewy, who first discovered the abnormal protein deposits, which are called Lewy bodies, that are responsible for the symptoms of Lewy body dementia. His research was in the early 1900s, where he was doing autopsy research with patients with idiopathic Parkinson's disease, and he was able to, when doing this research, he saw these deposits and protein deposits in the brain, certain areas of the brain, and so they were labeled Lewy bodies. In the 1960s, though, several pathologists described patients with dementia who had Lewy bodies. So still at that time in the 1960s, the cases were presumably rare. But as later advances happened and we were able to identify more Lewy body pathology, it was recognized as far more common than previously thought. So as we were able to advance research, pathology research, we were able to see that it's more of a common disorder than it was thought to be decades prior to the 1960s. So the term Lewy body dementia is actually an umbrella term for two related clinical diagnoses. And those two diagnoses are dementia with Lewy body and Parkinson's disease dementia. So Lewy body dementia, LBD, it is an umbrella term for two diagnoses. Oh, sorry. So once again, Lewy body dementia is an umbrella term for two diagnoses, dementia with Lewy body, or DLB, and Parkinson's disease dementia, PDD. These two disorders, they share the same underlying changes in the brain and share similar symptoms, but the symptoms appear in a different order depending on where the Lewy bodies deposit in the brain. So we'll unpack those two diagnoses a little bit in the next slide. I know that was a lot, but let's try to unpack that, as I said. So DLB versus PDD. The course of the disease, process helps in the differentiation between DLB versus PDD. So in DLB, dementia with Lewy bodies, the cognitive or thinking symptoms, so cognitive issues like thinking processes, difficulty with thinking, memory, things like that, those symptoms appear within a year of movement problems. However, in Parkinson's disease dementia, cognitive symptoms develop more than a year after the onset of movement problems. So just to recap that, with dementia with Lewy bodies, how do we come about that diagnosis is trying to figure out the timeline. Did cognitive issues come before the movement problems, or did some movement problems occur first? So in dementia with Lewy bodies, cognitive or memory symptoms appear within a year of the movement problems. And when I say movement problems, I mean tremors, stiffness, slowness, gait impairment, and things of that nature. But in DLB, we notice that patients have the memory and the cognitive issues first, prior to having movement problems. Conversely, in Parkinson's disease dementia, the cognitive symptoms happen afterwards. So the movement disorder, movement issues, tremors, stiffness, slowness, gait instability, things like that happen first, and then cognitive issues happen afterwards. And I go over this because the timeline of the symptom presentation is very vital in us being able to differentiate whether it's DLB or it's PDD that we are dealing with, because as both diseases progress, they kind of look like each other and they have very similar symptoms. So identifying that timeline is super important in getting a more accurate diagnosis. Next slide. So epidemiology. Lewy body dementia affects an estimated 1.4 million Americans. It's often misdiagnosed as a mental disorder or another form of dementia, so the prevalence is likely even higher than that. Dementia with Lewy body is the second most common form of neurodegenerative dementia in the elderly. The first, of course, is Alzheimer's disease. And findings from autopsies suggest that DLB accounts for about 10 to 20% of dementias. PDD, or Parkinson's disease dementia, each year about 14% of patients with Parkinson's disease over the age of 65 will develop at least some amount of mild dementia. So 14% of the total PD population, which is about 1 million by the end of 2020, about 14% of those patient population will have at least some mild dementia. Typically, Lewy body dementia appears at age 50 or older, although there are times that individuals who are younger will be diagnosed. LBD is more apparent or more prevalent, slightly more prevalent, I should say, in men than women. In general, though, the prevalence of dementia is steadily rising due to longer life expectancy. So, you know, it's great, we are living longer. However, the fact that we are living longer, it also accompanies the fact that dementias become more prevalent as a result. Economic burden. So dementia actually is one of the most expensive diseases in the US. It increases one's cost up to 3 times over the amount of healthcare costs of patients without dementia. In a recent study, 100% of the Medicare fee-for-service data was evaluated in California so that they would see what the direct health costs were and the utilization of costs of money for individuals who are diagnosed with dementia. In that study, Lewy body dementia was identified as actually the costliest form of dementia. The cost of the care for individuals with Lewy body dementia was about $22,514 per beneficiary. That was followed by the cost for healthcare of patients with vascular dementia, which was about $21,000. And then the cost of healthcare for patients with frontotemporal dementia, which was about $14,853. And lastly, actually, individuals with Alzheimer's disease had the lowest healthcare cost per person, which was about $13,935. So this pretty much just shows that Lewy body dementia, even though it's not as discussed and is not a topic that most of us know enough about, it does have a significant burden on our healthcare, and it's something that we do need to pay quite a bit of attention to. It's a diagnosis that deserves a lot more attention, I should say. And the reason I should say that the higher healthcare costs were associated with patients with Lewy body dementia, it was driven by more frequent visits to the hospital and more frequent usage of ambulances. So that's kind of why individuals with Lewy body dementia have more or higher healthcare costs than individuals with other types of dementia and individuals without dementia at all. Next slide. So pathology. The actual cause of Lewy body dementia is unknown. There's still research that's going into trying to figure that out, and Dr. Pavasia will talk about that a bit more later. So we don't really know what causes Lewy body dementia, but we know that there is some pathological changes in the brain, and the brain pathological changes are some selective damage to certain nerve cells, the neurons, in certain areas of the brain that are responsible for memory, cognition, and movement. These affected cells contain Lewy bodies, and Lewy bodies are these microscopic deposits or aggregation of a specific protein. The protein is called alpha-synuclein. And this protein is present in normal, healthy brain cells. It has great function. It does work. But in patients with Lewy body dementia, the protein, the alpha-synuclein protein, is misfolded. And this misfolded, abnormally folded protein interferes with cellular function and leads to cell death. So pretty much an important protein that is in the brain, it's misfolded, and it causes the nerves to not be able to work as well as it should, and eventually leads to cellular death. All right, to you, Dr. Pavasia. You're muted.
Oh, there we go. So let's talk about the diagnosis of dementia with Lewy bodies. Okay, how do we come up with the diagnosis? So, of course, there is a huge diagnostic criteria, but let's talk about generally what do we do in the practice as a movement disorder specialist. So diagnosis is complex. It's challenging due to overlapping symptoms amongst different neurodegenerative processes. And especially it kind of overlaps with the Alzheimer's disease, Parkinson's disease, symptoms. So patient and family may seek several physicians and neurologists' opinion before final diagnosis is made. One of the studies showed more than 75% of patients who have had dementia with Lewy body diagnosis were given a different diagnosis initially. So as you can see, even though we have diagnostic criteria available, it's still not very sensitive. Diagnosis is usually based upon thorough history taking, as Kim had mentioned earlier, paying special attention to the timeline of the symptom presentation, and as she talked about, trying to differentiate between Parkinson's versus dementia with Lewy body. Thorough neurological exam in the clinic, whether they have those movement-related symptoms, the tremor, stiffness, slowness, do a memory testing, brief and formal neurocognitive assessments that assess different domains of brain functioning. Those are all supporting the diagnosis of DLB. And we cannot do a definitive diagnosis. Just like any other neurodegenerative type of processes, we are only able to provide either possible or probable diagnosis at this time. We do not have any lab tests that can, say that this is definite diagnosis. So there was a, Lewy Body's consensus report that was done with the DLB consortium back in 2017, and these diagnostic criteria were made. I'm not going to go through the whole slide, it's pretty busy, but the main take-home point here is that the patient should have memory cognitive decline or behavioral problems such as visual hallucinations or delusions that can start much earlier in the course of the illness. And then within a year or so, they should have some kind of Parkinson-related symptoms such as slowness, stiffness, resting tremor, or rigidity. And then we can support the diagnosis with doing MRI imaging, the DAT scan, etc. And I'll go over that with you. And as I talked about, we can only give probable diagnosis if you meet certain criteria versus possible diagnosis if you meet, supporting criteria, etc. But it's very important to come up with the right diagnosis because the treatment options are different. So then how do we do this, diagnosis with supporting tests? So there are some blood tests you can do to rule out other causes of dementia if they're related to some other drug or, alcohol, increased alcohol intake, electrolyte abnormalities, nutritional deficiencies such as B12, B1 vitamins, and then other infectious causes such as HIV, neurosyphilis. Those things can also cause similar symptoms as dementia with Lewy body. So you want to rule those things out. The other big one is called hypothyroidism. You're probably aware of that. The hormonal imbalance can also lead to slowness, stiffness, tremor-like symptoms along with memory cognitive decline. So we want to rule out those things, and that's where the blood tests come in handy. Then we pursue MRI brain imaging, checking for brain shrinkage in parts of the cerebral areas, especially the temporal lobes, parietal and occipital lobes. These are the areas we're looking for shrinkage in those areas, which is advanced for their age. And then DAT scan, which is a nuclear PET scan, and checks for dopamine deficiency in parts of the brain. And I'll go over that in detail on a later slide. FDG PET scan is another type of PET scan, is checking for glucose metabolism in parts of your brain. And if you have dementia with Lewy body, then the typical pattern we see is the parietal and occipital regions have a reduced glucose metabolism. Of course, we want to do formal neuropsychological testing, which assess different domains of brain functioning, looking for any kind of subcortical or cortical dysfunction. Basically, in my clinic, if I have somebody who I think has dementia with Lewy body, for me, the history taking, the timeline, the neurological exam serves a much higher priority than this testing, the other supportive testing. I will still do them, but the diagnosis is still very clinical. So what does a DAT scan look like? DAT scan. The DAT scan stands for dopamine transporter scan. And basically it's a type of nuclear scan. It's not routinely done. This test is only done when there is overlapping symptoms of other types of illnesses. And it helps check the dopamine activity in the brain. And so if you look at the two images here, the one on the left side where it says normal, we're looking for the shape of the tracer binding or the radioactive material that they give you through the IV. And the shape of the binding looks comma shaped in the normal brain. And that is consistent with the normal dopamine activity in the brain. But on the right side, in an abnormal DAT scan, where patients may have either Parkinson's disease or dementia with Lewy body, they can have not a regular comma-shaped appearance. In this particular example, the shape is almost like a period. And so if patient has this type of difference, then we can say, oh, well, there's a less dopamine activity. So there are different types of shapes can have like a half a comma, pear shape, or a complete absence of the radio tracer binding. And this does help in certain situations when you have a lot of overlapping symptoms between, if you have a flavor of Alzheimer's disease and you have Parkinson type illness. So if you have too many of those overlapping symptoms, that's when we do the DAT scan. FDG PET scan for dementia with Lewy body. So here we're looking for that glucose metabolism. Brain tissue is very sensitive to glucose and it needs glucose constantly. So if parts of the brain is not functioning right, then the glucose metabolism will be much less. So that's what we're looking for in the FDG PET scan. Again, this glucose in this imaging, the glucose is bound with the tracer radioactive material. And so parts of the brain that doesn't metabolize glucose properly, then those areas would not light up properly. So in these areas here, in this example, the glucose metabolism is much less in the occipital lobe and with the temporal lobe, and it spares a particular part of the lobe called cingulate gyrus. So if we have a pattern like this, we can say, okay, well, this is supporting the DLB diagnosis. So diagnosis is challenging, in the patient in my clinic, I usually sometimes have to follow them. I may not come up with the diagnosis right away because they just have many symptoms overlapping. So often, we end up saying, okay, well, let's monitor this over the, several months to a year and see if there are any new evolving symptoms. And we have to do that sometimes to kind of get to the right diagnosis. And I will have now Kim talk about the treatment options for dementia with Lewy body.
So there are no treatments actually to slow or stop the progression of dementia, of Lewy body dementia. Yet there's nothing at this time that slows the brain cell damage. So current strategies are focused on more supportive management and also addressing and improving symptoms as they arise. So we'll go through some of the different symptoms and the different modalities of treatment. So initially the cognitive symptoms, so memory loss, loss of ability to focus, process, and things like that cognitively. Acetylcholinesterase inhibitors are the current standard of care for treating cognitive and psychiatric symptoms in Lewy body dementia. There are 3 medications that are FDA approved for the treatment of cognitive issues in Alzheimer's dementia. Sorry, Dr. Pavasia, can you go back? Okay. FDA approved for Alzheimer's dementia. So there are 3 drugs right now: donepezil, rivastigmine, and galantamine. These are under the acetylcholinesterase inhibitors category. Rivastigmine is the only medication that's FDA approved for the treatment of Lewy body dementia, specifically for Parkinson's disease dementia, but the other 2 are often used off-label because they can potentially help to slow the process. But once again, none of these can really stop the damage that has done to the brain. Memantine is another drug. It has a different pharmacological mechanism of action. It's also approved for Alzheimer's dementia, but not for Lewy body, but there are times that it is used off-label, usually with patients who have more severe dementia. Next slide. Parkinsonism. So as Dr. Pavasia mentioned, the Parkinson type symptoms that may come around that we may come up to with Lewy body dementia, the tremor, stiffness, slowness, gait issues. Levodopa therapy is an effective and is a relatively safe drug that is used in majority of patients with Parkinson dementia or Parkinson's disease, I would say. And so for patients who have Parkinsonisms in Lewy body dementia, we generally prescribe levodopa therapy. However, the comparison in terms of how patients will with Lewy body dementia versus Parkinson's respond to levodopa is different. Patients with Parkinson's disease tend to be more responsive to levodopa in alleviating their symptoms. Not so much with the individuals with Lewy body dementia. They can get improvement of their Parkinson type symptoms, but it's less effective in that patient population. And they have sometimes they are not able to tolerate higher doses of levodopa therapy, because as we go up and increase dopamine or levodopa therapy or add other dopamine class medications, individuals with Lewy body dementia are more vulnerable to having medication-induced side effects. So we have to be really careful about administering this medication. But once again, it is a treatment option. Levodopa therapy is a treatment option for treatment of the Parkinson type symptoms or motor symptoms in individuals with Lewy body dementia. Depression. So depression is very common in this patient population. So serotonin, selective serotonin reuptake inhibitors, that's a drug class that we use for patients for the treatment of depression. And the commonly used examples are venlafaxine, paroxetine, sertraline, and fluoxetine. So REM behavior disorder, that's also a very common symptom of patients in this population. And that is acting out of the dreams, talking while you're asleep, and pretty much, as I said, acting out your dreams. And we use melatonin, which is a safe over-the-counter natural substance to help with the reduction of that REM behavior disorder. That can be used as a monotherapy on its own, and a lot of patients do respond to melatonin on its own, but if patients do have persistent symptoms of the REM behavior disorder, we also prescribe clonazepam alongside melatonin. So behavioral changes that can happen with dementia with Lewy bodies. It can be difficult to address these behavioral changes because most of the typical antipsychotics and atypical antipsychotics that are generally prescribed for patients with behavioral symptoms, we really should avoid in patients with Lewy body dementia because it actually can exacerbate their symptoms. If there are like acute instances that patients really are having behavioral disturbances and it's very bothersome to their activities of daily livings and in general, we will prescribe quetiapine or clozapine at low doses if psychosis warrants any kind of drug treatment. A few published reports have suggested that maybe some of the acetylcholinesterase inhibitors, particularly rivastigmine, might help with some of the behavioral issues. But once again, that can be a really difficult and challenging symptom to manage for patients. So non-pharmacological measures are really, really as important in treating dementia with Lewy body. Building a care team, a team of supporting multidisciplinary approach to helping these patients with the different types of symptoms that they will inevitably have as the disease progresses. Physical therapists can help with movement problems. So it's very important that any patient with a neurodegenerative process, that they include good physical therapy, good exercise routine into their daily routine, because it will help with overall mobility and gait and strength and just their overall gait. It's very important. So physical therapy is an invaluable part of this team. So speech therapy can also be helpful. A lot of patients with dementia with Lewy body or Lewy body dementia have hypophonia, so lower voices, softer voices. So speech therapy, and they will potentially have swallowing difficulties as well. So speech therapists can really help with the voice training, voice projection, and swallow difficulties as well. Occupational therapists help individuals to find ways of easily carrying out their activities of daily living, such as bathing, eating, and things that are really important to help patients maintain some amount of independence throughout this process. Music and expressive art therapists also may provide meaningful activities to reduce anxiety and improving the well-being of individuals with Lewy body dementia. Mental health counselors, once again, another very invaluable part of this team. So counselors can really help patients with Lewy body dementia and their families to develop really good coping strategies as they deal with the difficult emotional ride that they might be on and the behaviors that they may experience. And they can also be helpful for planning for the future for patients and their family. Last but definitely not least, in the care building, like caregiver support is very, very important, because caregivers, spouses, family members, close friends are really, really important in the journey of individuals who are living with Lewy body dementia, because they provide the necessary support as individuals go through these inevitable changes as disease progresses.
All right, now let's talk about the prognosis of dementia with Lewy body. As Kim talked about, the treatment options are supportive, unfortunately, and there are some medication that we can try, but we still don't have actual FDA label indicated for dementia with Lewy body. So there are no formally defined stages of DLB like there is for Alzheimer's or Parkinson's. Unfortunately, there's still a lot of work that needs to be done in coming up with the accurate diagnosis. And the staging of this disease. The progression of DLB is marked by the increase in severity, frequency of confusion or psychosis symptoms over many months to years. So patients may start out slowly, with the memory cognitive decline. They may have mild hallucinations where they recognize that these hallucinations, seeing things that are not there, etc., it's not real. But as the progression happens, they lose sense of reality and they feel everything is real, whatever they're seeing. So the severity and frequency of this confusion and psychosis symptoms go up. Along with the worsening of memory cognitive decline, where they start being much more forgetful. They become less and less independent physically and mentally. Their thinking process is much slowed. They start to forget recent events or even the long-term memory starts to go as the disease progresses. And then they may have, start to have more behavioral disturbances, such as having more aggression, irritability. And so those mark the progression of the disease. So how do, patients with DLB pass away? And this kind of is a common theme for all neurodegenerative processes, such as Alzheimer's, Parkinson's. The death is usually due to infections of some sort, lung infection, pneumonia, urinary tract infections. They may get some other types of, respiratory cardiac illness that comes along the way, such as heart attack can happen, pulmonary embolism can happen. Or they may suffer a bad fall and sustain a bad injury where they may become bedbound, like a hip fracture or knee fracture, etc. So those are typical ways the patients, pass away, unfortunately. Now, one can always say, is DLB then deadly disease? The answer is no. It's usually DLB itself doesn't cause, death, but these are the other things, the other medical condition that can lead to the demise of a patient. So that moves to the next bullet point that, what is the typical lifespan of patients who have LBD? And per literature, it's anywhere from 5 to 7 years since after the diagnosis is made. However, this number varies, every patient is different. And so it depends on the rate of progression and the complications they may have. So if somebody has a diagnosis made today and they may cruise along fine, they may have a slow progression, and they may live up to 10 years. But then some patients may have bad fall and may injure themselves much faster, etc. And then they may have a shorter lifespan. So it really depends, every patient is different, but general idea is about 5 to 7 years. So then let's talk about this terrible illness. So what is being done? What kind of research is being done? Unfortunately, LBD was, first described 40 plus years ago, as Kim mentioned, the historical perspective that since Frederick Lewy found out about the Lewy bodies back in 1900, there was a period of silence. There was nothing no type of research being done. And then 1960s, they were, more confident that LBD exists. And then 1980s and 1996, that's when they first came up with the diagnostic criteria for dementia with Lewy body. So this disease is still very young, compared to Alzheimer's and Parkinson illness. But it is a top, it's among the top 3 causes of dementia in the US and worldwide. However, knowing all these facts, the research and its funding has lagged far behind Alzheimer's disease research and other common age-related dementias. As a result, the progress has been relatively very slow to date in unraveling the causes, the diagnostic criteria, the biomarkers, and improving our ability to treat this disorder. However, this has changed in the last, decade or so. So 3 things that, change, and that, the 3 key developments happen. So number 1 was an epidemiologic study revealed that the LBD ranks together with Alzheimer's disease and cerebrovascular disease, a major cause of dementia in the, aging population. The second key development was because LBD shares a lot of the clinical features of Alzheimer's and Parkinson's, so the research studies in these 3 disorders will be mutually synergistic. So whatever studies they're being done for Alzheimer's and Parkinson, they will relate to dementia with Lewy body. And then the National Alzheimer's Project Act, or NAPA, enacted by President Obama in 2011, to create a strategic plan to rid the nation of Alzheimer's disease and also neurodegenerative type of process such as LBD and other forms of dementia. So, we always gripe about, Obamacare being bad and, not so good, but here's one good thing that, he did when he was in the presidency. As a result of this development, so what is happening to LBD research? So the priority is dramatically rising, resulting in historic action. So for the first time, the scientific community developed a national LBD research strategy with an input from the Lewy Body Dementia Association and the patient advocates. And they, they were kind of, with the help of NIH and Alzheimer's disease-related dementia research summits, all of them kind of coming together now, and finally shaking hands and like, okay, let's take care of this. So a dramatic increase was made in dementia research funding in the fiscal year 2016 federal budget, and I'll kind of go over those budgets here in just the next couple of slides. And so the budget has gone up. However, there is quite a bit of discrepancy, which I'll talk about. NIH is now soliciting and funding research proposals to help achieve key research milestones in the Lewy body dementia. So let's look at some funding for the DLB. So as you can see in this graph, the dark blue bar is the Lewy body dementia. The light purplish is the frontotemporal dementia, and the vascular dementia is the dark gray. So as you can see, in 2012, 2013, there was no research funding for Lewy body dementia. And then 2014 and 15, that's when we started noticing some rise in the research funding. So now, what are these numbers? So these numbers represent dollars in millions. So in 2014, $15 million, and same in 2015, $15 million were contributed to Lewy body dementia research. I mean, as you can see, the numbers are definitely much lower than the other forms of dementia. But what about now, since 2016 through 2020? So I've highlighted the Lewy body dementia, and this information is obtained directly from NIH website. So as you can see, these numbers again represent dollars in millions of dollars. So Alzheimer research, as you can see, 2016 to 2020, after President Obama made BRAIN initiative happen with Alzheimer's disease research. So as you can see, those numbers are steadily rising for Alzheimer's disease, but I've highlighted Lewy body dementia. That still is lagging quite a bit. The most we have received in 2020 funding or estimated is about $76 million, compared to that, Alzheimer's receives $2,818 million. So, and other forms of dementia, they've received a lot more funding and attention compared to Lewy body dementia. So a lot more work needs to be done to raise awareness, do more studies, and trying to get more and more funding for Lewy body dementia at this point. So let's look at where do this money, where is this money being funded to? So I looked up clinical trials being done for Lewy body disease. And so I went to clinicaltrials.gov. That's the government website where they list any type of disease-related trials, whether it's investigational type of trials or diagnostic or interventional type of trials. So I, type in Lewy body disease. There are only 48 trials currently that were listed. Most of them were inactive or done. And so this included interventional drug trials, diagnostic imaging trials, and the only 3 of them were interventional drug trials, and they were active out of those 48. So let's talk about what trials are being done to accurately diagnose the disease, which includes the biomarkers and diagnostic imaging studies. So there are 4 of them that I've listed. The most common one, the first one, the observational study, which looks at different types of imaging to correctly diagnose, Lewy body dementia and other forms of dementia. The second one is a skin biomarker, which uses skin punch biopsy for the diagnosis of Parkinson's disease and dementia with Lewy body. The other imaging biomarkers using the PET scan, which we kind of talked about, the disease progression. How do we assess the disease progression in these neurodegenerative processes? So PET scans can be helpful. So that's the one study. Then the brain amyloid imaging with the Pittsburgh compound B, in part of the normal aging, mild cognitive impairment, and different types of dementia. So these are all studies being investigated to, help us properly diagnose dementia with Lewy body. Let's talk about those 3 clinical trials that can potentially help dementia with Lewy body patients. These are disease-modifying therapies where you potentially, if the medication down the road gets approved, then you can slow down the progression of the disease. So all the trials, surprisingly, they were all done at Georgetown University, or they were initiated at the Georgetown University. They're all in phase 2 of the trial. There are different phases, phase 1 through 4. Phase 2 is somewhere, kind of earlier phases. Phase 3, after phase 3, FDA can look into an approval of any medication. So, so all 3 trials are in phase 2. And looking at, the bottom 2 are looking at a cancer treatment that can potentially slow down the progression of dementia with Lewy body. The first one, K0706, that's just a number assigned. I don't know what the drug there is, but basically it's looking at the safety, tolerability, and effectiveness in dementia with Lewy body. So again, only 3 trials are looking at the medication to potentially slow down the progression of the dementia with Lewy body. There is another drug trial that was initially active, went into phase 2, and then became kind of inactive. So the status shows is active, but not recruiting at this point. So I'm not sure what is going on there. The second trial, I'm kind of excited about this one. It's conducted by Eli Lilly, and actually our practice was one of the site for this trial. And we had some patient enrolled in the Parkinson's disease dementia or dementia with Lewy body. This medication is supposed to improve cognition in mild to moderate dementia related to Lewy bodies. And so I did have about 5 patients enrolled in this trial, and the data is still not available yet. The phase 2 just completed in July of this year, and the phase 3 may start sometime in 2021. Of course, with COVID pandemic, things have been delayed, etc. But I'm very hopeful with this medication that, none of the medication that Kim went over, the Memantine, the rivastigmine, donepezil, or Aricept, these medications don't improve cognition. It just stabilizes it, okay, the memory loss, etc. But hopefully this medication improves the cognition and goes to the phase 3 and gets approved. All right, so what has been on the horizon? So in July 20 of this year, Acadia Pharmaceutical Company got a kind of a preliminary approval by FDA for Nuplazid. You may have heard of this medication. Nuplazid, or pimavanserin is the generic name. It's been FDA approved for Parkinson's disease dementia-related psychosis or Parkinson's disease-related psychosis. So patients who have hallucinations, delusions, paranoia, those type of symptoms, this medication is quite helpful. So the Acadia Pharmaceuticals did a clinical trial called Harmony Study, which met its primary endpoint, demonstrating that pimavanserin was significantly efficacious in reducing the risk of the psychosis symptoms by almost 3-fold compared to placebo, which is quite effective. And so we're hoping that in 2021, this medication will get approved for dementia with Lewy body to help patients who have, hallucinations or psychosis symptoms. So this medication is on horizon. Maybe in 2021 we'll get approved. All right, so let's come towards the end of the presentation, just a closing remarks. So LBD is the second most common form of chronic progressive neurodegenerative illness in the elderly population. Diagnosis is often complex and challenging due to overlapping symptoms amongst different neurodegenerative processes. Current treatment for LBD is symptomatic and supportive. There are medications available that are not robust, and it's not like a night and day of a difference when you take these medications. Unfortunately, prognosis is poor and based on patients' disease progression and complications. And funding for LBD research has increased over the past 5 years, but still trails behind other forms of dementias. And disease-modifying therapies, clinical trials are on the horizon and gives us a hope in the LBD community. All right, with that, we'll end the presentation. And let me open the chat room here, if I can find it where it is, and see if there are any questions. Okay, so we have received 2 questions so far. Are the costs per patient for 1 year? So Kim went over that cost, economic burden, and Kim, do you want to take that?
Yeah, so the study was in California based on the fee-for-service charges for Medicare claims. And yes, those dollar amounts was per year. So for Lewy body dementia, per year, the patient for the claims that were looked at, it was about $22,514 per year. So yes, to answer the question, it was per year, per individual, per beneficiary. So Lewy body was $22,514 compared to Alzheimer's disease, which is about $13,935 per year on average.
And just know that cost per patient per year is based on limited data. It was done just in California, that study. And so it doesn't represent the nationwide statistics, okay? That was just one study that we found was worthy of mention. They're not, and that is what is lacking. We need to look at the economic burden. Recently, the economic burden study of Parkinson's disease came in the picture, and the annual cost of nationwide, the annual cost of total of all the patients who get taken care of Parkinson, the annual cost is close to $40 billion. And so that's a huge number, right? And so something similar, epidemiology study would help. What is the economic burden of dementia with Lewy body, okay? The second question is, what is misfolded? And so I'll answer that. So basically, everybody has this alpha-synuclein protein in our neurons in the brain. And this, we still don't know to this date what is the exact function of this protein. However, when this protein gets misfolded, meaning, these proteins have a degradation process, a recycling process in our, brain, and like any other protein. And so when this recycling process gets damaged or is inefficient, this protein starts to kind of aggregate, and they start to misfold on themselves. And so that is what the misfolding of alpha-synuclein means. And when it starts to misfold, what happens, the brain, the other cells starts to look at this as this is abnormal, and let's clear it out. And part of the clearing is the death of the neurons. So what it does, it starts this cascade of events that leads to damage of these neurons, these misfolded proteins, basically. Okay. The next question is, how is LBD distinguished from Alzheimer's disease? Could it change over time? So the main criteria for Alzheimer's is basically you have memory cognitive issues, but much less behavioral issues in the initial stages of the disease. Compared to that, LBD can have behavioral issues such as hallucinations and psychosis, and those type of symptoms can occur much early in the course. The second part of the criteria for LBD is Parkinsonism, Parkinson-like symptoms. Alzheimer's patients do not get Parkinson-like symptoms. So typical tremor, stiffness, slowness, that can happen with the Lewy body dementia. Alzheimer's patients do not get that. So can patients who have Lewy body dementia go into Alzheimer's? Can this condition coexist? The answer is yes. It can coexist, and it's very rare, but it can coexist. Alzheimer's disease, the brain pathology is also very different. In Alzheimer's disease, the misfolding of protein, that protein is called tau, T-A-U. It is not alpha-synuclein. And also beta amyloid. So amyloid protein also gets misfolded. That's also part of Alzheimer's process. So in LBD patients, can get a little bit of tau protein and or beta amyloid protein misfolding happens, but however, majority is just the Lewy body, the alpha-synuclein protein that gets misfolded. Okay. All right. Next question is, my husband was diagnosed 7 years ago with DLB. He still has no PDD symptoms. Will he eventually get PDD? So the answer is it's unsure. If you have diagnosis of DLB, then that is the likely diagnosis. That means that you do not have PDD. PDD diagnosis is given when you have Parkinson's disease ongoing for X amount of years, and then you start having memory cognitive decline. And then you can have behavioral, hallucinations, psychosis symptoms. Then that's the diagnosis of PDD. Okay, the dementia with Lewy body, you have memory cognitive decline first, behavioral symptoms first, and then within a year you have Parkinson-like symptoms. So most likely, if he has been diagnosed with DLB for 7 years, it's less likely that he will have a PDD. The next question is, are we taking new patients? So answer is yes, we are taking new patients. Our wait time is not long. We can see patients within a period of, anywhere from 1 to 4 weeks, usually. We do take pride in spending time with our patients. We often get tertiary referrals, from other providers, meaning that patients have seen anywhere from 3 to 5 different physicians. They're not aware, they still have not come up with the right diagnosis, or they have not managed properly. So we see a lot of complex, complicated patients in those type of scenarios. But yes, we do spend a good amount of time the first visit and subsequent visits. All right. Is it possible to be diagnosed with DLB and frontotemporal dementia? So again, the answer is less likely. It would be very rare. Like I said, in frontotemporal dementia, the way you differentiate between the two is in FTD or frontotemporal dementia, you're not going to have Parkinson-like symptoms. In DLB, you will have Parkinson-like symptoms. So again, pathology is different in both of those illnesses. Frontotemporal dementia, again, is a tau pathology, meaning tau misfolding of the proteins, compared to DLB is alpha-synuclein predominantly. However, the behavior issue is somewhat different. Frontotemporal dementia have more behavior issues that consistent with, kind of getting more irritable, agitated, not keeping with the social norms. So doing inappropriate things or saying inappropriate things, that's more common in frontotemporal dementia compared to DLB. Okay, next question. In late stage of LBD, what are the benefits of Momentin? So in late stages of Lewy body dementia, the benefits of any medication is much less. So that includes Momentin, rivastigmine, or donepezil or Aricept. By that time, the disease burden is so high that this medication will have any impact, in stabilizing the patient. Now, I would say Momentin, rivastigmine, those medication has better utility in the early stages of LBD. Okay. All right, next, any suggestions regarding management of frequent falling and rocking behaviors in the late stage of disease? So again, the late stages, frequent falling can be mitigated by some physical therapy. And again, this becomes very challenging. We deal with this day to day in the clinic, where even advanced Parkinson patients, they have a lot of frequent falling. And by that time, they have memory cognitive decline. So even if you go through physical therapy, they may benefit from it initially while they're going through therapies, but then once they finish the therapy, they go back to their home or environment and they start falling again, just because they are not able to cognitively follow through the therapies, exercises, and such. So in late stages, it's hard to manage the falling, and at that time I just recommend using walker at all times, and or potentially even a wheelchair if they're falling constantly. The rocking behavior can be managed with some kind of antipsychotics, such as risperidone can help with the rocking behavior. Sometimes the antidepressants can also help. Rocking behavior is more what we call a stereotypical behavior, and the antipsychotics can be helpful. All right. Oh, thank you, Carisi mentioned for the presentation. I appreciate Carisi for setting this up, and and if you get any questions from the audience afterwards, just email us and we'll be glad to answer them.
We will for sure. Everyone, thank you all for joining us in today. Dr. Pavasia, Kimberly, we thank you so much, truly, from a person that sees the Lewy body with some of our patients here. Just know how much we appreciate you both and everything that y'all are doing. So thank you. And thank you for everyone who joined in with us today. We appreciate all your time, and we hope everybody has a great afternoon. I do have information on both of them. If you would like it, please email me and I'd be happy to share that. Thanks, and everybody have a great day.
Okay, thank you. Thank you all. Bye-bye.
Thank you.